So now we begin this session, and I wish Dr. R.K. Khemsura introduces the first lecture, who with the Dr. ASHWANI Kumar Sharma. He'll be talking about atrial fibrillation. Dr. Khemsura, please.
Good morning, all doctors. Dr. Meenao Saab, Dr. Ari Mathur Saab. Today we will be discussing the first topic. Our speaker is Dr. ASHWANI Kumar Sharma. He is MBBS DM Cardiology consultant at Fortis Escort Hospital, Jaipur. He has various publications in national and international journals. He is a principal investigator in various trials. His presentation in IGCTO 2019, CVT India 2019, and FESC program 2020. In current pandemic, constantly active on multiple platforms for case presentation, including coronary and peripheral. I hand over the mic to Dr. Ashwin Kumar Sharma for his talk on atrial fibrillation.
Thank you, sir. It's my privilege to have this platform for this live discussion. And so the atrial fibrillation is most common sustained arrhythmia diagnosed worldwide in adults. It is associated with substantial mortality and morbidity. The prevalence and incidence rises with the age, and currently in adult community the prevalence is between 2 to 4%, which is quite a good number. There are certain nomenclature related to atrial fibrillation, and we must know it well. Number one is the first diagnosed atrial fibrillation. When we diagnose atrial fibrillation first time in a given patient, irrespective of its duration or severity of the symptom, it is known as first diagnosed AF. If it terminates either spontaneously or by any intervention within 7 days of its onset, we do call it paroxysmal, and if it lasts more than 7 days, then we call it persistent. In the persistent, one category is long-lasting persistent. That means that atrial fibrillation is there for more than 1 year when we are deciding to either rate control or rhythm control. And we call it permanent when it lasts more than 12 months. But now the physician and patient both are agreed that we won't restore or maintain the sinus rhythm. So per se, permanent AF is not a pathophysiological diagnosis. It's an attitude of the patient and physician that now we will accept the rhythm in the atrial fibrillation format, and we won't attempt more to achieve the sinus rhythm. Having said that, we will just briefly focus upon the pathophysiology. So there are certain risk factors, out of which few are non-modifiable. For example, genetic component, age, gender, and racial ethnicity. Among the modifiable one, sedentary lifestyle, smoking, increased body mass index, obstructive sleep apnea, diabetes, and hypertension are there. Certain cardiovascular diseases predisposes to atrial fibrillation include heart failure and myocardial infarction. All these create the substrate for atrial fibrillation, in which there is fibrosis, which leads to slow conduction and electrical uncoupling, elevated inflammatory biomarkers, certain cellular and molecular changes, which all lead to the precipitation of atrial fibrillation. Once AF is there, then it perpetuates itself by electrical and structural remodeling, and all these things in turn leads to certain adverse cardiovascular outcomes in the form of stroke and systemic embolism, congestive heart failure, myocardial infarction, dementia, etc. Most of the patients of chronic AF are asymptomatic, and if symptoms are there, then it may be because of reduced cardiac output or due to the irregular fast ventricular rate. So patient may complain of palpitation, dyspnea, chest pain, dizziness, syncope. Then there are the symptoms of thromboembolism in the form of transient ischemic attack or stroke, or other mesenteric ischemia and other kind of systemic embolism. Once we diagnose a patient of atrial fibrillation, then certain diagnostic workup should always be carried out, which include ECG documentation of atrial fibrillation, a meticulous evaluation of history, careful clinical examination should be performed, and simultaneous assessment of associated or concomitant cardiovascular pathology should also be carried out in these patients. A transthoracic echo is mandatory in all AF patients. It guides further management, which we will discuss soon. Usually we don't go for long-term ECG monitoring, but in certain circumstances we do it, particularly when the patient is having well-controlled rate and the symptoms are not controlled. So then we would like to know that whether the symptoms are correlating with the brief burst in the rate of cardiac rate or something other causes. So this is the classical ECG of atrial fibrillation. We see that there is no P wave and irregular RR interval is there. Sometimes there are fibrillatory or F waves. In the management strategy, in acute atrial fibrillation, we focus upon the rhythm control as well as rate control. Then we pinpoint and manage the precipitating factors, say maybe lifestyle changes, treatment of heart failure, treatment of underlying myocardial infarction. After that, there is assessment of systemic embolism and stroke risk and its adequate management, apart from the rate and rhythm control. All these treatments are directed towards the symptom control, hemodynamic stability, cardiovascular risk reduction, and prevention of stroke and other systemic embolism. So the current ABC pathway of treatment focuses upon three main points in the form of A for anticoagulation to avoid the risk of stroke. We'll just briefly discuss it in detail. B for better symptom control, either by rate control or rhythm control. And C stands for the comorbidity and cardiovascular risk assessment as well as its adequate management. In atrial fibrillation, it's not the diagnosis of AF which is worst, rather its complication in the form of ischemic stroke is the most important and most important outcome which should be adequately dealt. Non-valvular AF is associated with the risk of stroke fivefold more common than a patient without AF. And risk of stroke and other systemic embolism is similar, whether it is paroxysmal AF or it is sustained AF. And we do classically assess the risk by Church or Church-West score. In this graph, we can very well see that the patient who are at low or moderate or high risk of stroke, in both the cases, whether intermittent AF or sustained AF, the risk is almost equal. So once there is a significant risk of systemic embolism and stroke, we give patient oral anticoagulation. So there is classical vitamin K antagonist as well as newer therapies in the form of newer oral anticoagulant. Not all the patients are eligible for NOAC, and the classical contraindication is a mechanical prosthetic cardiac valve and moderate to severe mitral stenosis, which is usually rheumatic in etiology. So once a patient is there with AF and the absolute contraindication in the form of mechanical heart valve and moderate to severe MS is ruled out, then we assess the risk of systemic embolism as well as stroke by Church-West score 2. If score is 0, these patients are absolutely at low risk of stroke, so we don't give either anticoagulation or antiplatelet. A score of 1 in male and a score of 2 in female. Here the risk is low, but it is definitely there, and we classically prescribe them oral anticoagulation. Indication is class 2A. And when the score is 2 or more in male, 3 or more in female, it is a classical indication of OAC, and it's a class 1 recommendation. In these patients, we preferentially give newer oral anticoagulant or vitamin K antagonist, and if there is absolute contraindication, then we offer the LA appendage occlusion to these patients. So if we go by the recommendation, then in a score of 2 or more in male and 3 or more in female is class 1 recommendation, as we have already discussed. And NOAC are preferred one over the classical vitamin K antagonist. This has been highlighted in 2016 ESC guideline as well. And currently in AHA guideline also the same is there. So we'll just throw some light upon the Church-West score and Hasbled score. So Church-West score assesses the risk of stroke, and it includes the congestive heart failure or low left ventricular ejection fraction, hypertension. Age more than 75 accounts for a score of 2, while 65 to 74 accounts for a score of 1. Then stroke or TIA, it carries a score of 2. Vascular disease in the form of previous myocardial infarction or peripheral artery disease and or aortic plaque, it constitutes a score of 1. And finally, female gender carries a score of 1. So the score varies from 0 to 9. In that study, the maximum score was between 1 to 5, And very high score are seen in less number of the patient, but the higher is the score, more is the risk of stroke. So the score of 0 and 1 in male and women respectively is truly a low risk patient, and we don't give anticoagulation or antiplatelet to these patients. After assessing the risk of stroke, we assess the bleeding conditions. It includes hypertension, abnormal renal and liver function test, previous stroke, bleeding, labile NR. Labile NR means that time to therapeutic window was less than 60% of times with the warfarin or acetron. Then elderly, consumption of certain drugs, and alcohol. So the score varies from 0 to 9. A score more than 3 carries a high bleeding risk. Once there is a high bleeding risk is confirmed, it doesn't say that oral anticoagulants are contraindicated. Rather, it underscores the fact that the modifiable factors should be diagnosed well and should be controlled well so that the blood score can be reduced. So if hypertension is there, especially BP is more than 160, it can be very well controlled. We have a good armamentarium of antihypertensive drugs. Label INR should be more closely monitored, and necessary precautions should be executed as if the patient is not taking precautions with green leafy vegetables, then that should be exerted. Certain medication in the form of antiplatelet should be modulated accordingly. NSAIDs should be withheld. Excess alcohol consumption can be curtailed by the psychotherapy, psychosocial help, as well as the need of medication. Then among the other potentially modifiable factors, anemia, impaired renal and liver function should be taken care, and so about the reduced number of the platelet or altered platelet function. So conclusion is that in indicated patient, even if the His blood score is high, we should potentially decrease the factors which lead to increased bleeding risk. Now we'll talk about certain pivotal trials of oral anticoagulants, newer oral anticoagulants. So we know that the coagulation cascade begins with extrinsic or intrinsic pathway, and then it comes to a pathway where factor 10 is activated, leading to activation of thrombin, and which in turn activates the fibrinogen with the clot formation. So dabigatran is antithrombin, and apixaban, rivaroxaban, and edoxaban inhibits the activated factor 10. In the journey of evolution of oral anticoagulant, initially in the 1990s came the trials of warfarin, and in 2009 onward comes the dabigatran, rivaroxaban, apixaban with latest addition of edoxaban. However, edoxaban is not available in India as of now. If we talk about the cytochrome P450 mediated metabolism in the liver, then dabigatran is free of this metabolism. Dabigatran is ingested as a prodrug, and it's hydrolyzed by the stage mediated hydrolysis step. Majority is excreted in the kidney. Its bioavailability is low. And rivaroxaban bioavailability without food is 66%, but if we give it with food, then it reaches almost 100%. So rivaroxaban should always be given with food. With apixaban, its majority is metabolized by liver, and in edoxaban, it's 50-50. So in this chart, we would try to compare the pivotal trials, but mind it that the population of patients in these trials was quite significantly having different characteristics. So we can draw conclusion, but it will a conclusion of preference rather than anything in absolute number. So in the Relay trial, dabigatran was given in the form of 150 milligram BD dose, 110 milligram BD dose, and then warfarin. And almost all were equal in proportion. While in Rocket AF trial of rivaroxaban, low dose rivaroxaban was given 20% of the patients who received rivaroxaban. And in Aristotle, the apixaban low dose was still on low side. So what we see that the prevention of stroke and systemic embolism was much better compared to warfarin with the dabigatran 150 milligram. It was equal with 110 milligram BD dosage. With the rivaroxaban, it was not superior. And in Aristotle trial, apixaban was superior to warfarin. So 150 BD and dabigatran and apixaban 5 BD are superior to warfarin for prevention of stroke and systemic embolism. The prevention of ischemic stroke was achieved with only dabigatran 150 BD dosage, and hemorrhagic stroke was prevented by all the drugs. So we can say that the hemorrhagic stroke is one of the kind of fatal bleed. It was prevented by all the NOACs compared to warfarin. Now, if we talk of the safety endpoints, then major bleeding was equal to warfarin with 150 mg dabigatran, but it was low with 110 milligram dabigatran. Again, it was low with the apixaban and edoxaban. IC bleed was low with all the drugs compared to warfarin, and this GI bleed was little high when we gave the dabigatran in 150 VD dosage and rivaroxaban on high doses. In patient with acute atrial fibrillation, the acute control of heart rate will be governed by the 2D echo findings. If the patient has EF of less than 40% or symptoms of congestive heart failure, then we avoid the rate controlling CCB or beta blockers. Preferentially, we give the amiodarone. With the target of resting heart rate below 110, we can add digoxin. If EF is good, then we give beta blocker or CCB. In long-term management, we are finding if EF is low, now we will gradually institute the beta blockers and we will gradually increase the dose because the beta blocker also provides the motility advantage. And if it is well preserved, then we controlling CCB or beta blockers as patient or intent on when our focus is of rhythm control. Of receptive, if patient is hemodynamically unstable, then we will go for urgent DC cardioversion. If he is stable hemodynamically, then we have a due counseling, and if patient electively agrees for the electric cardioversion, we offer that. Otherwise, we go for pharmacological cardioversion. In patients where there is a low EF and or significant aortic stenosis, we classically give intravenous amiodarone bolus followed by infusion. If patient is having underlying coronary artery disease or low EF or left ventricular hypertrophy, then we have the options of amiodarone and vanagliptin. If there is no structural abnormality, then we have two options, IV and oral. In oral, we classically give pill-in-pocket therapy, where we give the plecanate and propofenone with rate controlling agents, either beta blocker or CCB. Otherwise, in intravenous route, we give plecanate, ibuprofen, propofenone, and vanagliptin. And for long-term rhythm control, the patient is having no structural heart disease, we have a good option of dronidrone, plecanate, propofenone, and sotalol. Otherwise, we can give amiodarone. Catheter ablation is class 2A indication. When there is a structural heart anomaly, then we don't give the plecanate and propofenone. And in patients of heart failure, we give the amiodarone as well as the rate controlling drugs. Thank you. Thank you for kind attention.
Thank you very much, Dr. Ashwin Kumar Sharma, for a very nice presentation on atrial fibrillation. Is there any question from audience? Please, you can ask Dr. Ashwin Kumar Sharma.
If there are any questions, please put them on the chat box.
Dr. R.S. Gehlot sir, Dr. R.S. Gehlot sir.
I thank you for the nice presentation. Are you able to listen to?
Yes.
Because there was some problem. I was not able to hear for a long time. Anyway, but whatever I seen the slides, these were very good slides, and I think this is one of the common problem which we come across in our clinical practice. And there was a nice presentation and clear guidelines how to use the different drugs at different time. I congratulate for the nice presentation. Thank you.
One question I want to ask Dr. Ashwin. How often we see hyperthyroidism in patient with atrial fibrillation? How often
Yes, sir,
we
in
see hyperthyroidism?
And that's quite common. In the population of atrial fibrillation, we do see hyperthyroidism as a standalone entity very uncommonly. And this is the classically group of the patients where we can first manage the hyperthyroidism before initiating the anticoagulation, and we classically give the beta blockers, which antagonize the effect of thyroxine hormone as well as it acts upon the rate control.
There's one more question. What is the role of lanoxin now in atrial fibrillation?
As of now, we give the lanoxin only in the patients who are having low ejection fraction and where there is not adequate control with beta blocker and rate controlling CCBs. Otherwise, upfront we don't give, because we have in these patients the beta blocker will provide the mortality advantage. Those CCB won't provide any mortality advantage, and with digoxin we don't see these advantage. Only the prevention in the hospitalization is there. So our first choice would be beta blocker and rate controlling CCB. But if patient is hemodynamically unstable, say patient has come with the septic shock or other kind of shock, now we can't give beta blocker and CCB. These are the candidates where we give intravenous amiodarone and digoxin.
Okay.
Thank you very much, Dr. Ashwin Kumar Sharma, for the nice presentation.
Most welcome.
Now we go for the next topic.